بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. Good time for everybody. I'm Dr. Asiri, consultant, clinical radiation oncologist. I'm happy to talk to you about surveillance and follow-up of cancer patients. We're going today to talk about the follow-up and surveillance of patients who survive cancer. And as you know, cancer is not killer disease all the time. There is a lot of people who will survive the cancer. And survival generally for cancer is more than 57% of all kinds of cancer, especially hematological malignancy and breast cancer, colon cancer. And those people, they will survive the cancer and they need special care for the following years after their completion of treatment for cancer. The objective of this talk is to explain the importance of cancer patient follow-up, describe the follow-up process, describe the benefit of providing a patient with cancer information for appropriate follow-up, and explain follow-up plans for different common tumor sites. Purpose of follow-up in cancer patient to ensure continued medical surveillance for this patient and monitor the health status of the population under investigation and detect residual or spread of disease after the completion of treatment. Rationale of follow-up for cancer patient. Surveillance program should be guided by a presumed risk of recurrence and functional status of the patient. Distance patient home of cancer facility is important, but need to be taken care of. Surveillance tests should not be performed if patient is not fit for any treatment. So the surveillance program must be decided depends on the type of cancer and whether this cancer is one of the cancer that recur. If we take skin cancer, for example, usually this kind of cancer do not recur and there is no need for long-term follow-up for these patients. But there is cancer with high frequency of recurrence like breast cancer, and they need a specialized program for detection. The program of follow-up should be tailored for the patient situation. If the patient coming from far distance, then you need to decide about what kind of test, especially if the patient traveling for long distance. And when he comes, he may need special investigation, for example, imaging. And sometimes he need to wait where he's going to do this investigation. So you have to take care of this while you design the program for follow-up. If the patient is not fit for further treatment, probably you have to think again about the benefit of doing investigation and doing tests for this patient. The patient always is the best source for information. For information, most of the cancer recurrence will be known by the patient before the physician, and it will be felt by the patient before it is detected by imaging. So history taking is important to know whether this patient is suffering from a certain problem. For example, if you look to breast cancer patients with brain metastasis, usually you will have some neurological symptom before you detect the cancer by imaging. And unfortunately, there is a lot of imaging done for cancer patients, which is sometimes not recommended and would not help to improve the patient outcome. One of the side effects of cancer therapy is second malignancy. If you look to chemotherapy-related leukemia, especially after alkylating agent, it is usually within the first 10 years. It starts in the second year after the completion of the treatment, and it will peak at the 5 years, and it will decline till the 10 years, and after 10 years, you don't see any further leukemia-related, chemotherapy-related leukemia. And the leukemia related to the chemotherapy is of myeloid type. Radiation therapy also can cause second malignancy, and it takes usually longer latency and started from 5 to 10 years after the completion of radiotherapy. And usually it is related to the site of the radiation, and in most of the cases it will be sarcoma if it is in the site of the radiation, and it is myeloid leukemia if it is in the bone marrow. It is very important to document the follow-up for this patient, and that will help for the research. It helps to detect major side effect of therapy used for cancer patient, and it will help to improve the standard of care for cancer patients. Prevention of recurrence and the new cancers. Why we do that? Because cancer, one of the known behavior of cancer that is spread or recurrence, and by follow-up or surveillance program, you will detect cancer spread at early stage. And this may not help patient survival, but it is important to know the prognosis and to do intervention for this. In addition to that, all the patients, when they come for follow-up of cancer, they have some psychological disturbance, and doing this type of investigation, if it's negative, will reassure the patient and improve his or her psychological status. And the other side, that you interfere if there is any recurrence or if there is any major complication of cancer therapy, like lymphedema or some changes in sexual behavior or symptom related to cancer therapy. For example, if you give radiation therapy to prostate cancer, sometimes the patient will have painful defecation or painful micturition, and that will help you to decide what kind of intervention you decide after that. Risk of recurrence depends. Cancer do recur commonly, and following the primary treatment of cancer, any patient is at risk of recurrence, and this recurrence usually related to the grade of the tumor, related to the stage of the disease, and related to lymphovascular invasion. And the recurrence usually either local in the tumor bed or a distance far away from the primary. If it is, we can call it local recurrence or distant metastasis, depend on the site of recurrent disease. And the timing for recurrence vary between cancers. Some of the cancers recur within years, and some of it recur within decades. So it depends on the type of cancer and the behavior of said cancer. Surveillance for second cancer, in addition to recurrence of primary malignancies, cancer survivors are at high risk for secondary malignancy, not only as part of cancer therapy, but also probably some cancers share the environment, the risk factor, and the genetic changes for the primary cancer, and the cancer patient always at high risk of developing other cancer. Cancer survivor may be at high risk for second cancer related to the lifestyle. For example, smoking can cause lung cancer, and at the same time can cause lip or throat cancer, laryngeal cancer, or esophageal cancer. So this type of cancer is common in patient who smoke, and they may come at different years. So also the patient who have some genetic changes or mutation, like mutation of retinoblastoma gene, RB gene, or tumor suppressor gene, TB53, they are at high risk of cancer development because they have weak tumor suppressor genes. Patients who are treated for Hodgkin lymphoma and oral cavity malignancy may be at high risk of secondary malignancy, likely related to the treatment of lifestyle. Treatment and lifestyle. Monitoring for cancer recurrence, long-term and late effect of cancer, and its treatment in addition to secondary cancers. Cancer survivors are at risk of for other conditions related to both their disease and its treatment, which are of increasing importance as survival rates improve. Side effect monitoring. Cancer patients receive different modality of treatment, like surgery or chemotherapy, radiation. Each one of them carry specific side effect related to the treatment. If you look to the chemotherapy, it has a broad spectrum of side effects like nephrotoxicity, cardiac toxicity, pulmonary toxicity, peripheral neuropathy, and ovarian failure. And based of the chemotherapy used in follow-up period, you have to look for the specific side effect of chemotherapy, which is related to the type of the chemotherapy and related to the disease. In patients who have cardiac toxicity from anthracycline chemotherapy or trastuzumab, echocardiography is important as modality for investigation. Patient with pneumonitis, CT scan is a good modality for surveillance, and also pulmonary function test. And ovarian failure, if the patient received alkylating agent or a specific chemotherapy which affecting the endocrine function of the ovary or testis, need to have follow-up with a specific blood test to see the function of the ovary. And other chemotherapeutic agent which cause nephrotoxicity, patient required to have blood test to measure the kidney function test. In addition to that, mental health. Cancer patient, they will have moderate to severe psychological distress experienced by cancer survivor and also their caregiver, because cancer will affect the family integrity and affect the work and income for the patient, and this psychological status need to be followed and monitored during the follow-up. Also, cancer may affect the employment and ability to work, insurance level. So, because cancer patients usually their premium insurance usually high, so physician should think about this and support the patient for that, and also to help them for disability program. And the coordination between specialty is important, because cancer patients may require to see different specialty, surgery, oncology, radiation, rehabilitation, cardiology, and so on. So coordination between these specialties is important to support the patient and during his follow-up. Cancer itself cause anxiety, cause depression, cause fatigue. Some of the cancer therapy cause cognitive disturbances like radiation of the whole brain. It will, or resection of part of the brain, or some chemotherapeutic agent which given intrathecally may affect the performance of the patient, either school performance or memory, and need to be supported. And some of the cancer patients, they have some limitation in their higher mental function. At the same time, it may affect the sleep, rhythm, and also it may cause some sexual problem. So the physician may suggest for the patient some intervention like exercise or group therapy, or to be part of a cancer support group to cope with this kind of disease. The physician and the caregiver would be advised to give the patient the option of getting some sort of support, and it can be discussed further with a cancer support group who help patients to cope with their disease. It is common for cancer patients to have psychiatric issues, especially fatigue and depression, and sometimes they get disturbances of sleep, and they may have a chronic pain problem, and this is an area where cancer care provider will be advised to take care of it. In cancer therapy, cancer is common disease in pelvic area, either in ovary, uterus, cervix, in addition to vulva and vagina, and it causes major disturbances for hormones of the ladies because the main standard of care for gynecological cancer is hysterectomy and bilateral salpingophorectomy, so the source of hormone will be removed. Same time, radiation therapy will affect the ovaries, and it will not produce estrogen or progesterone. So the cancer survivor, and these patients usually survive because the outcome of cervical cancer, uterine cancer, is quite good, up to 80% survivor, but they will have difficulties in sexual behaviors, especially loss of fertility as part of anovulation, and also they will have some problem with libido. So they need to be supported for that from their physician. Sexual problems are reported by survivor of gynecological malignancy. Not only that, but even for survivor of cancer generally, breast cancer patients also they have some psychological problem and gynecological problem related to the chemotherapy. So they will have some early menopause, dyspareunia, and primary loss of libido, loss of desire. It was reported in more than 57% of ovarian cancer that the treatment altered their sexual life and affect their relation with their spouse or their husbands. In one study, reduced interest in sex was reported by 54 and 31% of survivors with early and late stage epithelial ovarian cancer. In addition to 41% and 46% reported decreased sexual activity. So it is an issue, and it will affect the quality of life. Patients need to be supported during the follow-up of patients, either by psychological program, psychological support, sometimes by some lubricant, and we not advise generally hormone replacement therapy because it causes another problem, which is it can cause secondary malignancy in this patient. So it is not advised to prescribe hormone replacement therapy. We mentioned that hysterectomy and chemotherapy or hormone therapy cause early menopausal symptom like flushing, sometimes cause nausea, dryness of the vagina, and lack of interest or pain during the relation, and that's need to be helped through lubricant and sometimes dilators. If the patient had radiation therapy to the vagina, they will have some stenosis and can be helped by a specific tailored dilator of the vagina. Hormone therapy, as we mentioned, is available, but it carries the risk of second malignancy. So there is alternative to it called phenylaxine and other selective serotonin reuptake inhibitor, SSRI. These treatments help the patient to cope with the sexual problem related to the cancer therapy. As a result of cancer therapy, body image get affected in a significant way, either on the image itself, especially in breast cancer where the patient had mastectomy, so the hair image will be affected by the treatment itself. Sometimes alopecia and a change of voice, change of face for head and neck cancer. So this poor body image will affect badly the sexual relation between the spouse, and it needs to be supported during the follow-up. Some patients will have colostomy and or cystostomy, and these patients will have difficulties and need to be supported by the caregiver. A lot of cancer therapy cause sterility, and fertility is an issue and need to be addressed either before the start of chemotherapy for sperm banking or ovum freezing, and also the patient need to be alert before the start of treatment and need to be supported after the treatment. As we said, cancer therapy gives some anxiety to the cancer patient because they are worried about their children that they may get cancer because they have thought that cancer is inherited. So they have some thought about cancer and also history cancer for their children. They get worried about that. If the patient can conceive in the future, they may have the risk of congenital anomaly for their children, and they usually worried about this. And a lot of patients, if cancer patient, they could get pregnant after therapy, especially lymphoma, Hodgkin lymphoma, they could conceive after cancer therapy, but there is worries or anxiety about their pregnancy and risk of abortion during pregnancy, so they need to be supported for that. Genetic counseling, now BRCA test is available for patients who have cancer in the family, and genetic counseling is important, so they can do genetic test, and the geneticist could give the patient some information about the risk of cancer in the future, either in the patient himself or in the offspring of the patient. But genetic testing is not 100% accurate. So before going to have the genetic testing, it is important that the patient be consulted about the potential ramification of test, and also to know the consequences. Sometimes, if you do a BRCA test and it is positive, the patient may advise to do prophylactic mastectomy bilaterally, which is not an easy decision for the patient. So the patient has to be informed before he underwent this genetic testing, and to know the psychological result of doing the genetic test and the risk of developing cancer in the future. If there's any particular mutation identified, so that may affect the future plan for the patient to get a specific investigation, and the frequency of investigation may be changed, depends on the risk of developing cancer in the future. Cancer survivor should be tested, particularly if her own children and first-degree relatives are also interested in their personal genetic susceptibility. Now we'll move to a specific kind of cancer, and we will think about the program for the follow-up. Colorectal cancer in Saudi Arabia is a common disease. 900 cases of colorectal cancer being discovered annually in Saudi Arabia, and the cancer rank the first among male population and third among female population. The overall age standard rate was 8.6 for 100,000 of population. The 5 regions with highest ASR were Riyadh and Eastern region. Mecca is the third, Qasim follow, and Medina is the fifth. The age at diagnosis, the median age at diagnosis is 59 years for male and 57 years for female. In colorectal cancer, it is important to do a thorough history and physical examination, in addition to CEA blood test and liver function test, in addition to colonoscopy every 6 months. CT scan is an important tool for the follow-up, and it is recommended annually for the first 3 years to detect any local relapse or liver metastasis. PET scan should not be used for follow-up in colorectal cancer. Surveillance colonoscopy is important and should be performed on the first year and usually 1 year after the surgery and after the completion of therapy, and after that every 5 years to look for anastomosis recurrence or new development of other lesion. In addition to, it is important to keep secondary prevention like maintaining healthy body weight and lifestyle. 5 years following initial resection, if there is no evidence of recurrence, CA testing should be discontinued, and abdominal CT scan. CA testing is an important tool for follow-up and should be discontinued after 5 years of follow-up. The CT scan, abdominal CT scan, shouldn't be used for everybody, but patients with high risk of recurrence, especially young patients. CT scan also important if there is any change on the CEA or liver enzymes. We move now to breast cancer, which is a very common disease. And the NCC guidelines and ASCO guidelines recommend history and physical examination every 3 to 6 months for the first 5 years, and then every 12 months. Mammography should be performed annually, and bone density should be monitored if the patient on an aromatase inhibitor, which causes osteoporosis. Annual gynecological examination is important for patient who is on tamoxifen therapy, because tamoxifen causes endometrial hyperplasia and sometimes endometrial cancer. There is no rule for tumor markers, so there is no specific blood test for breast cancer follow-up. Prostate cancer, it is a common cancer in males, and the follow-up for prostate cancer depends on rectal examination and PSA, which is prostate-specific antigen testing. There is limited evidence for benefit of PSA testing in more than 5 years in prostate cancer, and guidelines from expert panel include the National Comprehensive Cancer Network and American Cancer Society recommend PSA testing every 6 months for 5 years, and then after that it could be done annually. All survivors with an elevated or rising PSA level after treatment should be referred back to their primary prostate cancer specialist to see why the patient failed treatment and to go for salvage therapy. Digital rectal examination also is important to detect prostate cancer at the beginning and also detect recurrence of prostate cancer. And should be coordinated among provider to avoid duplicate, because prostate cancer patients sometimes seen by urologists and radiation oncologists and medical oncologists. So the follow-up must be coordinated between this specialty, and to minimize the number of digital rectal examination which may affect the patient. Digital rectal examination is not important for patients who had prostatectomy, because there is usually nothing will be felt rectally by digital examination for patients who underwent prostatectomy. And also after radiation therapy, the prostate will be firm, and it is not easy to detect recurrence if the patient had radiation therapy. So the best surveillance test for these patients is blood test with PSA. Some of the prostate cancer patients, they will not have any treatment, and they will be for observation only, and these patients require repeat of the biopsy every year to see if the Gleason score of the patient change with the time. So these patients who did not receive prostatectomy or radiation therapy, they need to have biopsy every year to check the grade of the tumor, which may differ from the initial Gleason score for the patient. And ovarian cancer also is very common women malignancy, and the National Comprehensive Cancer Network guidelines for monitoring women who have completed treatment for epithelial ovarian cancer. They should have a regular visit to their oncologist, and during the visit they should have a physical and pelvic examination every 3 to 6 months, up to 5 years post-treatment, then annually. CA125 test is important in ovarian cancer follow-up, and should be done every visit, especially if it was elevated at the initial presentation. For the role of CA125 surveillance for women with epithelial ovarian cancer, it was tested before. Usually after the completion of chemotherapy in ovarian cancer, the CA125 come down around 0. And then after that, the patient will be considered in complete remission. There is several studies checked after that whether to start the treatment at the time of rising of the CA125, or to delay it till the patient develops symptom. It was found that the patient who had the CA125 test and rise and start chemotherapy early, there is no difference in overall survival whether the treatment started with the start of the symptom or when start of rising of CA125. So it is not recommended to decide your treatment based on CA125 only. But the resection of the tumor or debulking will be easier when the CA125 is low, because the volume of a tumor will be less. Ovarian cancer in Saudi Arabia, there is 160, around 160 new cases every year in Saudi Arabia, and it is about 3.5% of all new diagnosed cancer among ladies. And it is not that common compared to the breast cancer or others. The median age for ovarian cancer is 55 years of age. As you mentioned before, the benefit of CA125 testing is debatable whether to decide treatment at the rise of CA125 or to leave it till the patient develop a symptom. There is a study from Medical Research Council of UK, which is 05 trial, where they check 1,400 lady where their CA125 tested, and they compare these patients to the patient with disease without testing, and they found there is no major benefit of starting treatment based only on the CA125 testing alone. But the patient with rise of CA125, probably they will benefit from secondary debulking or surgery at the beginning of the rise of CA125. So immediate treatment was not associated with longer remission duration following the detection of recurrence. However, it resulted in an adverse impact on quality of life, despite the result of the Medical Research Council 05 trial following patient longitudinally by CA125 may help identify patient for surgical treatment. In a study of 74 women with recurrent epithelial cancer who underwent secondary cytoreduction, a shorter time interval from the initial rise in CA125 to surgical intervention was associated with a higher likelihood of an optimal cytoreduction to less than 1 centimeter residual disease. So the bottom line here that it is good to do cytoreduction at the time of the rise of the CA125. If you're going to do chemotherapy, it's better to wait till the patient develops symptom. Modern method of follow-up is not necessary for the patient to come to the hospital every time. For the follow-up, can be done by a nurse-led clinic, by telephone, telemedicine, follow-up letters to the primary care physician, which may be not applied in Saudi Arabia, but also outreach program, our shared care program could help in follow-up for patients. And the follow-up can be done in the local hospital rather than in tertiary care hospitals. This is one example of nurses in UK where they visit the patient and they do a blood test and they help the patient not to travel to the big cities or a tertiary care hospital to do their follow-up. Take home message from this, that surveillance follow-up is aimed at detection of residual disease, or it is recurrence or additional malignancy. Surveillance program should be guided by the presumed risk of recurrence and functional status of the patient. There is good evidence that the surveillance may improve clinical outcome by early detection and intervention. After that, we included a few cases for you for study, and it is some sort of breast cancer, ovarian cancer, prostate cancer. So I advise you to go through the cases and see the scenario for the follow-up programs. And there's a few messages that we would like to let you know about it, that this information is not confidential, and this information can be given to the cancer registry staff who collected the information about the patient. And as you see here, there is different cases with different diagnoses, and I hope you enjoy the scenario for the follow-up of these cancer patients. Thank you very much, and I hope you enjoy the lecture. Thank you.